Okay.
So as you all know, it's a challenge for any of these secondary IOL fixation techniques, and
Amazing.
one second, sir. So your screen, there are two screens, sir. I'm not able to see that screen. Close, close. Very close. One second. It's not, the screen is not showing.
Or you can set it right, and by the time Manoj can go. Huh? Nivean, let's not waste time. We don't have much time.
Or just let it run.
Manoj, go this side.
Let's say that.
Hmm? Sure.
Just a video, sir. Yeah, I'm sorry for this thing. Yeah, so the first half will be on the retropupillary iris claw lens. So as you all know, it was Wurst who first described this. So he was actually inspired by the claw lobsters that made him design this. So it's the IOL as such is a relatively simple design. It's an one piece, one material, and the whole mechanism is based on how the iris tissue gets.
1 minute, Nivean. Can you reset the timing? Yeah, thank you.
Yeah, so the whole mechanism is based on how the iris tissue gets enclaved within the lenses. So I'll just show you the surgical video. So as you can see here, there are two things that are important here. One is to know where you're going to clip the iris and where the tissue is going to get stuck. And the second thing, the use of the right forceps. You need a slightly broader forceps, because if you use a normal forceps, sometimes it slips and you don't get that good grip. This is called the Shepherd's forceps. And also sometimes you have to check these lenses. For most of the time, sometimes it can be fused and then you go inside and then you keep pressing and you cause more damage to the iris. So these are just some simple tips before you start off with the procedure. So basically, this is an old aphakic patient where we had planned for a retropupillary iris claw lens. As you all know, since it's a rigid lens, so you'll have to do a sclerocorneal tunnel. For any secondary IOL, always stain. I think my mentor, Dr. Montrajan, already emphasized on this for two reasons. One, once you stain and wash, you can see the vitreous clearly, even though at the start of the case, it didn't look as if there was much vitreous. The second, that little amount of the vitreous that goes inside also helps in preventing post-op CME. So it has a double advantage. So do a good vitrectomy, because for any secondary IOL, a good vitrectomy is the key, because later on you don't want vitreous in the section, which can increase the rate of endophthalmitis or cause any peaking of the pupil. So as long as the claw lens, again, just the tricks, I do a method in which I take my left hand inside first to the area where I want to clip. This is very, very crucial, the mid-periphery of the iris, because if you go too anterior, that is when you get these cat-eye shaped pupils, and sometimes when you go too posterior, you can damage the root and can cause bleeding. So I always take my second instrument first to the place where I want to clip, and then I take the lens inside and then clip it. So the later on videos, I'll slow it down slightly and show you. Here again, you can see my second hand is already waiting where to the place I want to clip. Then the lens goes inside and then the clip. So in the second case, so then the positioning, always 0, 180 degree is ideal. So here the second trick is you push your right hand up and push down your left hand. So when this happens simultaneously, it is also easier to clip these lenses rather than going and searching, because intentionally what happens, the hand where we're holding the lens keeps going down and you keep pressing. So you're not actually going to get that iris tissue getting enclaved. So whichever hand is holding the lens, go underneath and lift it up. So you see that small bulge that comes on the iris, and then the second instrument pushes it down slowly here, and then you see a small dimple. That dimple is a sign that some amount of iris tissue is enclaved. It doesn't have to be full thickness into that. It can just be a small dimple that you can see here. You can do this in other combined cases also. So the basic thing is for the iris claw lenses, one, you need a good round pupil. That is the only indication, I think, where there is a bad pupil or where there's an iridodialysis, this lens cannot be done. This particular case, it had glaucoma also, so the glaucoma surgeon did superiorly at the trab, and then we did the temporal. Why I wanted to show in these cases, in these sometimes old aphakias, the pupil is very rigid, and sometimes we get this iris starring when we do these lenses. So the third trick here again is good amount of viscoelastic, hold the lenses. The second instrument can be used to guide the iris. So you don't have to, I've seen sometimes people forcefully taking the second haptic down under the iris, so that time also it can cause damage to the iris and bleeding. So use the second instrument, stretch the iris, take the lens down gently, and then clip it. So again to the mid periphery. So we routinely do not do a PA in these cases because we have done a large case series which was published in IGO, which compared and said that is not the only sole reason for the claw lenses causing glaucoma. But this particular case, because it was a known glaucoma patient, we did the PI. Yes, complications are there in every secondary IOL procedure. You get irregular pupil, iris bleeding, iris tear, breaking of the haptics when too forcefully done, or non-clipping. So this was one of our publication, and the second publication or the contraindication is you get something called the pseudo-phacodonosis. So I was fortunate enough to work with Dr. Amar sir, and then we compared between glued IOL and these claw lenses, and these patients having this complaint of pseudo-phacodonosis because it is attached to the iris. So these are some of the disadvantages, but you get round pupils and good dilatation so that the fundus examination can be seen even in these cases. Moving on to the second part, the CMT flex IOL, so no financial interest. So this basically is a single piece hydrophilic lens which has got specialized T-shaped haptics on both sides. So when these T-shaped haptics are brought out of the sclerostomy, opens up and gets fixing there. So that's the basic principle on how these CMT flex lenses work. So this was one of the first designed IOL for aphakic management. So again, we'll go through the basic principles for any secondary IOL. So here we have a case of aphakia. So the first thing is the 0-180 degree marking, so which is very crucial for any of these secondary IOL procedures. So here we are just using the Ashwin's glued IOL marker to make the 0-180 degree mark. And on both sides, a 2 by 2.5 millimeter partial thickness clearal flap is fashioned using a crescent blade. So now once that is done, measuring 1.5 millimeters away from the limbus, a 23 gauge sclerostomy is done. So this sclerostomy either you can do with a needle or you can use your 23 gauge MVR blade also. So you can use the same sclerostomy to do the vitrectomy. So once the vitrectomy and the cortex is removed, so these are the specially designed T-flex forceps. And this other advantage of this lens is it can be done through a clear corneal incision. It's a foldable lens. So as you can see, once you inject the T-shaped haptic coming out first, so ideally if you can grab it, what is called as the head-on position like this is the ideal position, because when it comes out through the sclerostomy, it bends forward and it's easier for the lens to come out. But you can hold the neck or the arms off the lens also. The second point is at this point, just inject the remaining of the lens. Don't pull it out because it's a single piece lens, so it can actually detach. So just hold it and wait for it. Inject the remaining of the lens. Leave the trailing haptic either in the wound or over the iris, so wherever you're comfortable, and then slowly pull out. At the sclerostomy side, you're going to have a tug because that is where it's going to come out. So don't be in a hurry to pull it out. Just give it a tug. You'll see the T opening up and stays there. So just a small animation clip. It can be loaded and done in any of the regular IOL cartridges. Just the routine 2.8 millimeter incisions in the clear cornea. So there's no special cartridge for this. Just make sure that the T haptic comes out first. So when you load it by yourself, so that way it makes it easier to hold it. So once you hold it, inject the remaining of the lens and then you bring it out. And for the second thing, you use the handshake technique, as you can grab one arm of this and using the second Pranav T-flex forceps. So we also have the Nishi grasping forceps. Basically they have serrations because it's a hydrophilic material. You don't want any sharp instruments holding it and biting into the lens. So here exchanging the other hand, and being a hydrophilic material, it is very tissue forgiving and it is flexible. So you don't have to worry about any tissue damage inside. So once you have a good hold, and then now you bring out the other side. So once that is done, because of the 0-180 degree marking, then you don't have to do anything else. The lens sits in place. The third thing that we have done is there is a small angulation between the optic and the haptic. So basically that prevents the iris from rubbing it and having pigment dispersion. So you have good dilatation post-operatively. You can glue the flaps and the conjunctiva, or you can suture the conjunctiva, or you can even cauterize it. So I think you can do any of the two, because once that is done, because of the thicker haptics, there is no leakage here. So this is the day one post-operative pictures, a few corneal folds. As you can see, nice round pupils. And these are some of the studies that we did with UBM to show the positioning of the lens and also long-term effects. We almost have a 5-year follow-up now. So how the sclera behaves where the T junction is outside. So this can be combined with other challenging cases also that I'm going to show you now. So this was another case post-trauma. This you can see a cystic bleb also and superior iridodialysis. So here again the other advantage is you can measure any 180 degrees. So you can even go vertically or horizontal. So basically here again you can see 1.5 millimeters away from the limbus. And you can avoid other areas. So this you can see is the lens. I usually load my lens myself so that make sure that I get the T haptics out first. And there's also a dialing hole, as you can see on the top right. So that also gives you the clue that that is how the angulation is there. So it doesn't flip the other side. Some of them use that dialing hole also to hold it with the dialer when they do the handshake technique, isn't it? So there are other reasons why you can use the dialer. So here again you can see, even though it looks decent, it is because of the superior iridodialysis. I think SFT is a brilliant and very easy technique for any of us to do. So we did the single pass 4th row pupilloplasty here to get the pupils back into anatomical position. So as far as anterior segments are concerned, yes, the main secret for any secondary IOL is the hypotony. So make sure your globe is not hypotonous when you do any of these secondary IOL procedures. So I would suggest definitely use a AC maintainer or a trocar AC maintainer. Because we are surgeons, I prefer using the trocar because that is easier to do actually, because now all of you are trained with intravitreal, so it is not very difficult. But this particular case, because the eyeball was formed, we didn't use any of the two. But again, there will be a challenge if it starts shallowing. So I would suggest not to do unless you use a AC maintainer or a trocar maintainer. The message is it can be done even by anterior segment surgeons. So this was one of the modifications of the technique where we just do a partial groove. I think the other people who have done modifications like using the Hoffman's pocket also, they have done it so that the haptics get buried under the Hoffman's pocket. Here again exchanging the other hand. So this was an old SICS patient with asteroid hyalosis who was referred to us for aphakic management. So here again, as of now there's only one standard IOL design, so hypermetropes should not be a problem. Sometimes myopes which have high axial length, you either have to come at least slightly closer to the limbus. And for any secondary IOLs, just make sure at the end of the surgery, you just check as long as there is no vitreous in the anterior chamber. Even though you have done a good vitrectomy, this is another thing you can always do, just put in some tricot and then just check as long as there is no vitreous in the anterior chamber. And again, we had glued the grooves and the flaps. Yes, there can be breakage, or sometimes when you use these sharper VR instruments, it can bite into the material. And late dislocations we have not had, but certain cases of iritis, but it is as comparable to any of the secondary IOL procedures. So it was a long journey of 7 years from the drawing board to what it is, and people have started using it, and we have a lot of publications. So once again, like to thank Dr. Mohan Rajan and Sujata ma'am for this wonderful opportunity, and Dr. Amar sir for always being inspiring. And if you have seen most of my videos, I think every time when he innovates something, I try and use it, and the next year he comes up with another innovation. So thank you, sir.
Thank you, Nivean, for the wonderful innovation, and it's going to be, I'm sure, it's a game changer for all of us. Before Manoj goes on to the drop IOLs, I want a quick poll. How many of you do iris claw lenses? Yeah, it's a very simple, easy technique. How many of you do glued IOLs? How many of you do sutured scleral fixation? Quite a good number. How many of you do AC IOLs? How many of you leave them aphakic? That's also a good option. That's why I wanted to know. If you have any problem, if you are not able to decide where your capsule is, sometimes the pupil becomes small, put iris hooks, okay, you know exactly. Sometimes you put a lens on the capsule, thinking it's sulcus, next day it will be on the retina. So if you have any problem because the pupil becomes small, your mind is also agitated, you can leave the patient aphakic, and after a couple of weeks you can take them, assess them on the slit lamp. By the time there will be a fibrosis of the capsule as well, and you can put a lens easily in the sulcus. So over to Dr. Manoj Khatri. He's a senior PR surgeon of Rajan Eye Care, and he's going to talk to us on dropped IOLs, which is again very, very important.